Welcome to the Johns Hopkins Medicine online webinar series. Today, Johns Hopkins bariatric surgeons, Dr. Michael Schweitzer and Dr. Katherine Lamond, will be speaking about surgical weight loss options 101. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenters. The last 30 minutes will be dedicated to our live Q&A session. Please note this program is being recorded. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note if you do not want your name attached to the question, please check send anonymously. Also, your email address will not be shared with any third parties. We will do our best to answer all questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Michael Schweitzer and Dr. Katherine Lamond to begin our presentation.
Good afternoon, everyone. Hopefully everyone can hear me okay. I'd like to welcome everyone for the afternoon. I'm Dr. Katherine Lamond, and halfway through the presentation, Dr. Michael Schweitzer will take over. I'd like to provide a little landscape about our program. Johns Hopkins has two major bariatric centers. The first is based at Bayview, Dr. Schweitzer's center, and then my center is at Sibley Hospital, which is in Washington, D.C. We are located approximately 40 miles away, but we do like to align our programs, and a lot of our protocols are very similar, and we follow each other very closely. Our websites are combined, and there's a fair amount of information that you can find on the website. There are seminars that we give individually as well if you want to hear more from either of us individually. But at the end of the day, this is going to be a lot of information that you're going to see today. So please don't feel like you need to take frantic notes for two reasons. One, this is videotape, so you can watch it as many times as you like. And secondly, this is really just the first step of your journey. So you will hear a lot of this terminology and vocabulary as we proceed through the process. Just to outline a little bit about what you'll hear today, I will discuss a little bit about what bariatric surgery is and why or why not it may be an option for you. And as I said, about halfway through, I'll turn it over to Dr. Schweitzer. He will discuss a little bit of our data as a center and what your typical experience will be like when you have surgery with us. And with that, we will get started. This first slide, I think, is really, really important for everyone to sort of acknowledge and understand. I could talk about just this slide for about an hour. And really what this means is that obesity is complicated. There are a lot of things involved that make up obesity: genetic factors, environmental factors, behavioral factors. And it's important that we understand that there's a lot of overlap. And fortunately or unfortunately, a lot of family and friend networks may just think it's one of these bubbles. But indeed, there's a lot of overlap. There's a lot of what we don't understand about obesity as well, especially in this box, the genetic box. We understand, and there's a lot we don't understand yet. There are many treatment options available besides surgery, most certainly diet, exercise. There's medical therapy available and behavioral therapy. Of course, we're here today to discuss surgical management, but all of these modalities are very important to acknowledge and understand. Surgical management has been proven to be more beneficial in the long term in terms of weight loss and, most importantly, curing medical problems. This is not a cosmetic procedure. Bariatric surgery can cure medical problems, and that is what we're here to talk about. Weight loss is sometimes a byproduct of bariatric surgery. We want to cure your diabetes, high blood pressure, high cholesterol, and that helps you live longer. In order to be a candidate for bariatric surgery, the NIH came up with criteria in the early 90s, and you have to be over a BMI of 35, perhaps with an obesity-related health condition, such as high blood pressure, high cholesterol, sleep apnea, diabetes, or osteoarthritis. Talk you through this in terms of your insurance policies and whether or not they accept a lot of these conditions. If you're over a BMI of 40, we'll discuss in a few minutes, you may not have to be diagnosed with one of these conditions. There are a few other things that are listed. A lot of what we'll discuss today about the process of undergoing bariatric surgery does have to do with what the insurance companies require. And that is an important part of the process for us in order to have your insurance carrier cover your surgery. It is really important to have realistic expectations and the support of your family and friend network. No one can do this alone. When you undergo surgery, it is a health risk for you, and you need to understand some of the risks that are involved. This is a bit about BMI. Most people have heard about a body mass index. You can Google BMI and find out what your BMI is. It is not my favorite number. It's not perfect, but it's the number we have at this point to communicate with the insurance companies and with other physicians in terms of your body weight and height ratio. You can see here that the morbid obesity is technically a BMI of over 40, which at times correlates with a BMI of over 100 pounds. That's not a perfect analogy, but that's essentially where we are in this discussion. We talk a lot about EBW, which is excess body weight. So for an example, if we had a patient who was 250 pounds and per the BMI guidelines, their ideal body weight should be 150 pounds, the difference there is 100 pounds. In terms of the excess body weight, it's 100 pounds, and if you were to be able to lose 50 to 75% of that, that of course correlates to about 50 to 75 pounds. Some of these health risks I discussed a little bit earlier, but obesity-related health conditions increase your risk of heart disease, diabetes, high blood pressure, etc. Specifically, I want to outline the bottom. It increases your risk of cancer, and having any of these conditions on the list decreases your life expectancy. And the reason we go forward with bariatric surgery, as I said, is to cure these health problems so that you live a long, healthier life. So bariatric surgery options that we offer in the Johns Hopkins system are mainly these procedures: the laparoscopic vertical sleeve gastrectomy and the laparoscopic gastric bypass. You're thinking to yourself, well, I've heard of some other things. I've heard of the laparoscopic gastric band. I've heard of the balloon. These are some things that we can certainly talk about in clinic, but we as a Hopkins system have removed more bands than we've ever placed. And that's because there's long-term consequences with having a band, and it's not a long-term viable option for appropriate weight loss and curing medical problems. So we're going to focus today on both of these laparoscopic options. Laparoscopic surgery may be a familiar concept to most of you, which has to do with using small incisions while we operate on a monitor. It's less painful, which means you're up and walking sooner, which means it decreases your risk of a blood clot, decreases risk of wound infection and overall complications, and it gets you back to your life sooner. As a Johns Hopkins systems, we've performed over 6,000 bariatric surgeries since late 1997 when the program started. So I'm going to move on to the first surgery, which we'll describe, which is the sleeve gastrectomy. This is technically the newer type procedure, and it's only newer because the insurance companies didn't cover it for a while. We've done this for 15 plus years, and it's not a newfangled concept, but it is new in the sense that insurance companies are justifying that it does indeed work. It does not involve intestinal rearrangement. There's less malabsorption issues than gastric bypass, and I'm going to take you through a movie as well. But essentially, what you can see here is that we remove this part of the stomach here, which is about 60 to 70% of the stomach tissue that's removed. So you have less of a reservoir in order to accept the food. So it restricts the amount of calories that you take in, and therefore you lose weight. You're left with about a banana-shaped stomach. And again, I'll play a video about this as well. There are risks and benefits of any surgery we do, specifically the benefits to the sleeve. Again, decreased intestinal malabsorption. It preserves the pylorus, so it decreases the risk of dumping syndrome. There's less risk of a bowel obstruction. The average weight loss, or excess weight loss rather, is about 50 to 60%. And we'll compare the operations later in the presentation. Risks, surgical risks of both surgeries include bleeding, infection, damage to things nearby. In terms of the long-term risks, in theory, the stomach may stretch over time. This is pretty rare, especially if you follow our education program and follow along with us as part of the program. Another complication could be a leak from the staple line. It's your body's job to heal over the staple line, and if there's an issue there, that can be a problem. The opposite of a leak almost is a stricture, where your body heals the staple line almost too well and things can be too tight. With either of these issues, we have ways of fixing the problem, sometimes endoscopically, don't always need a repeat surgery. Lastly, it's very important that you discuss with your surgeon if you have a diagnosis of gastroesophageal reflux disease, because it's really important to choose wisely in terms of what surgery you're the best candidate for. Here's our movie. Don't worry, it's all cartoon. I'm going to play it now, and there should be a voiceover in the background.
A thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy.
Excellent. So I'm sure that sparked a few questions in people's minds. We're happy to take questions again at the end. But just to reiterate a bit about what she said, the part of the stomach that disappeared, it actually does go away. It can't be put back in. This is not a reversible type procedure. We'll move on to talking about the laparoscopic gastric bypass. Again, we use small incisions for this. This looks more complicated, and frankly it is. There are more parts to this operation. There are two major parts where we create a stomach pouch, and then we rearrange the intestines in a safe way to essentially absorb calories we need and nutrients that we need, and we don't absorb calories that we don't need. I'm going to play a video about this. In general, the gastric pouch that we leave is about half the size of the sleeve, so it's about 30 milliliters. It's created with a similar gastrointestinal stapling device. The roux limb, or the limb of bowel that's created here, is about 60 to 150 centimeters. And in terms of long-term excess weight loss, it is mildly or slightly higher than compared to the gastric sleeve, which is about 60 to 75%. This is our gold standard operation. We've done gastric bypasses since the 1950s. When we were able to make the switch to laparoscopic surgery in the early 90s, it was a great decrease in morbidity and mortality. Patients tolerated this much better, and people do very well with this operation. Again, there are risks. There's more operating that is done here. Marginal ulcers are ulcers that can form where the stomach and the intestine meet. We talked about stenosis, similar to a stricture with the sleeve. Anemia, or any deficiencies in any of the purposeful malabsorption that is created. Dumping syndrome is something that it can occur if you have a high carbohydrate load, which is pastas, cookies, and cakes. The intestine is not used to seeing a lot of those nutrients that aren't digested yet, and that can result in cramping and diarrhea. It doesn't happen to everyone, and it doesn't happen all the time, but it's something to know about in terms of risk. There are many benefits, as I've already mentioned, for the laparoscopic gastric bypass in terms of weight loss, and more importantly, with reduction of obesity-related conditions, specifically with type 2 diabetes. We like to cure type 2 diabetes, and we can sometimes do this with a gastric bypass within days of your operation. So if you have type 2 diabetes, it is very important for you to consider the gastric bypass, and certainly discuss that with the surgeon. Here is the video, and I'm going to play this. Sometimes I play it twice. It's a little more complicated.
A small stomach pouch is created. Stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested.
Excellent. So again, I'm sure there are questions spawned about the bypass, and we will certainly answer them at the end. I'm going to go through this last slide and then turn the presentation over to Dr. Schweitzer. In general, there are risks that we will discuss with you in terms of the bypass and the sleeve. Just undergoing an operation, undergoing anesthesia puts you at risk for blood clots, heart attack, or a stroke. We most certainly put you through a rigorous preoperative process to make sure you're as optimized as you can be for surgery to decrease any of those risks. It's important to talk about these risks with your surgeon to make sure that you're comfortable with them, but have a realistic approach to undergoing an operation, knowing that the benefit in the long term is to help you live longer and healthier. And with that, I will turn the presentation over to Dr. Schweitzer.
Great, Dr. Lamond, thank you. I want to thank everyone for taking time during their lunch to listen to us. Give me 1 second here to share my screen. And go up. Okay. So I'm going to talk about some data or articles that have come out on gastric bypass and sleeve gastrectomy. However, there are thousands of articles, so I've picked a few. One of the first ones that was published in the New England Journal of Medicine, obviously a well-respected journal in the world, mostly medicine docs refer to it, as well as the press. But this was by Dr. Adams out of the Public School of Health in Utah. He's not a bariatric surgeon, so it's one of the reasons why I chose it. And what he did in his group, they looked at almost 8,000 gastric bypass patients, and they matched them with patients who were morbidly obese who didn't have gastric bypass. And at 7 years, what they found is there was a 40% decrease in the rate of death if you had surgery, meaning if you had surgery, you were less likely to die than if you didn't have surgery. And 40% obviously is a large number. The reason for the decrease was a decrease in heart disease, diabetes, and cancer in the patients who had gastric bypass surgery. Just today, an article came out showing a decrease in pancreatic cancer in patients who are morbidly obese and have diabetes. So even more data keeps coming out showing that it's better to lose weight and not be morbidly obese, and it decreases your risk of death and other diseases, obviously, such as heart disease, diabetes, and cancer, and more. We've looked at our outcomes. This was an article we published some years ago looking at 1,000 patients at our center. In this group, we had no mortality. The anastomotic leak, meaning a leak rate in gastric bypass patients, is about 0.4%. If you took all our patients, it would be just under 0.3%. With the sleeve, it's even less than that, so it's pretty low. Blood clotting is about 0.5%. And important, looking at diseases that are relieved, cured by having gastric bypass surgery and losing weight. Hypertension, 73% resolution. Diabetes was 75% resolution. GERD or heartburn with gastric bypass was 91%. And that's why Dr. Lamond had alluded to it's important to tell us about your GERD. We will ask questions about it, and we will do studies to look into it because gastric bypass works better for GERD patients than the sleeve gastrectomy. Sleep apnea, there was a 93% resolution where most patients got off of their CPAP device. Looking at weight loss, 1 year to 5 years. At 1 year, most people lost most of their weight, 61% after gastric bypass. By 2 years, it was up to 67%, and at 5 years, it was 64%. After gastric bypass, most patients lose the bulk of their weight or most of their weight in the first 6 months, and then you continue to lose some weight for the next year. So somewhere between 12 to 18 months, you hit your plateau as far as weight loss. With sleeve gastrectomy, it's about 9 to 12 months where you hit your plateau. So if you were to, I recently put together all the data from all the centers in the US. They're submitted to a national database. And in this very large group of patients, those that had laparoscopic sleeve gastrectomy lost 50% of their weight loss from ideal body weight, body mass index, and gastric bypass, it was 62%. Before surgery, their BMIs were over 40 in both categories. But after surgery, most dropped down to the low 30s, if not under. This is a study out of Switzerland looking at sleeve gastrectomy versus gastric bypass. It was a randomized study, which in many respects are the best studies out there. They looked at, again, sleeve gastrectomy versus gastric bypass. There was 107 patients in the sleeve gastrectomy group and 110 patients in the Roux-en-Y gastric bypass group. These are very difficult studies to do because, as you can imagine, most patients don't want to be randomized. They want to choose the surgery they want after talking to their doctors and their family. So these patients agreed to be randomized to either group where they didn't have a choice. And what they found out is basically the weight loss was about the same in both groups after about 36 months. They had excellent follow-up, which is one of the reasons I point this out. In Switzerland, everyone has health care and it's much easier. People don't move around as much as they do in the United States, and it's much easier to follow them. So they had 97% follow-up at 3 years. And the weight loss was about the same, around 70%, 73%. The sleeve is quicker operation, but as we've been talking about, gastric bypass was more effective in the patients who had GERD and also who had high lipids or high cholesterol. But again, the weight loss was about the same. So this study was a follow-up. If you remember, Dr. Adams was mentioned in the first study I talked about. He's out of the Public School of Health in Utah, and his group did a follow-up study, which again, I think is important. And this was recently in the last few years. And they looked at 418 patients who had gastric bypass surgery versus 738 patients who did not. And their follow-up rate was excellent, which is really hard to do in the United States. It was over 90% at 12 years. And the surgery group, on average, lost 77 pounds, but the non-surgery group only lost 6 pounds or less over that time. In the surgery group, diabetes resolved in 75% of patients at 2 years and 51% at 12 years. And what they found, and others have found too, is the sooner you got surgery, the better you did, not surprisingly. If you wait to a long time while you've been an insulin diabetic and you're on a lot of insulin, then you're less likely to fully correct. Most patients get better, but you may not fully correct after surgery. However, obviously, you're on less insulin or less medication, you're better off. With that said, I've certainly had patients who have been on 100 units of insulin twice a day and have fully corrected. When I say you're less likely, it goes down to about 50%. It's not 0%. Most people benefit from the surgery, and obviously they benefit greatly if you're a diabetic. At our centers, we have special care teams. They are exquisitely trained on taking care of our patients and helping them and their families. These are some of the rooms that we have that are made for bariatric patients. Most of our patients, whether you have a sleeve gastrectomy or gastric bypass, go home on day one, the next day after surgery. We do send you home on a special diet. You will meet with the dietitian and go over all that. The first week is basically full liquids. It's liquids and protein drinks. The next 3 weeks is a puree diet. It's high in protein, about 60 to 80 grams. Water intake or fluid intake is very important. We want you to get about 64 fluid ounces per day. You know you're hydrated if you're urinating. If you're urinating just one little squirt of orange a day, that's not hydration. And we would spend a lot of time talking to you about this and making sure you stay well hydrated after surgery. You know, it's just like spraining your ankle. Your ankle may swell. Well, having your stomach stapled, the stomach swells for a little bit and then the swelling goes down over a week or two. So we really want you working on just getting your fluids in the first week. With that said, most people aren't in pain when we see them in the office at 2 weeks. They may take a few pain pills when they go home, but most just go on Tylenol for that time. We don't want you lifting over 15 to 20 pounds in the first 4 weeks. We just don't want you to get a hernia through the small incisions. But we do want you walking and going out. Routine exercise is fine. Again, no heavy lifting for those first 4 weeks. And most important for the women, we want you to plan. We don't want you to get pregnant in the first 18 months while you're losing weight and you're taking your vitamins and keeping up with your nutrition. That's not a good time. But on the flip side, realize you will be more fertile than you've ever been. And so for those who have infertility problems, it's clearly shown that getting surgery and losing weight will make you more fertile. In fact, that's one of the reasons why we see our patients. So you do need to use a birth control method to prevent pregnancy in the first 18 months. We will counsel you. We don't like you to use estrogen products around the time of surgery, meaning the first month before and a month after, because they can cause blood clots. But after that, that's fine. IUDs, Mirena is fine. And again, please ask questions when you come see us about this. We'll be glad to talk to you about it. We will send you home on a multivitamin, calcium citrate with vitamin D. If you're menstruating, most menstruating women need iron. You will need vitamin B12. It's under the tongue that we usually have you take it. And then patients who have their gallbladders, we do send you home on a medication that decreases your risk of gallstones from 32% to 2%. And we do ask that you take it for 6 months. After 6 months, it doesn't help. You will meet with a dietitian to go over that. And I'll be glad, Dr. Lamond and I will be glad to answer any questions you may have. Okay. Stop sharing. Okay.
Take that one. I think there's a question coming through. The question is, how do you determine which procedure to do on a patient? Great question. We talk about this a lot. Again, you'll have a session specifically with Dr. Schweitzer, one of his partners, or myself, and we talk about a variety of things, specifically your medical issues. So that will revolve around any medications that you take, any baseline past medical history that you have, specifically whether you have diabetes, whether you have reflux disease, apnea, those other comorbidities that we discussed. We also do some studies to determine whether you're a candidate for the sleeve versus the bypass. Typically, we do an upper endoscopy, which is a procedure within the first month or two after seeing us for the first time. And this upper endoscopy helps evaluate whether you have esophagitis or an irritation of the esophageal lining from reflux. Sometimes that reflux can be silent. And we really want to know if that is present, because we would certainly try and do a gastric bypass for you in those circumstances. We also certainly take into account your comfort level. Some people, you know, I'd say it's probably 50-50. Some patients walk in the office and say, no chance I want a bypass because I don't want to be rearranged on the inside. And the other half come in and say, no chance I want a sleeve because I don't want my stomach removed. So everyone has sort of their own comfort level. It does, at the end of the day, come down to a team decision between you and your surgeon, and taking into account the medications you take, as I mentioned, and your medical history.
Good. I'll take the next one. It's if I have weight loss surgery procedure, will that mean I can't get pregnant? No, actually, it's better to have a weight loss procedure. There have been studies showing that losing weight after gastric bypass surgery or sleeve gastrectomy, you're at less risk for pregnancy or during pregnancy and having a baby. So it's better that you have weight loss surgery. We just want you to wait 18 months because that's when you're losing weight, and that's not a great time to have a baby. But certainly after that, you're at less risk than if you were to stay morbidly obese. Obviously, we can't randomize patients to get pregnant or not, but looking at large databases, we can tell that patients who get weight loss surgery do better if they get pregnant. It's just that first 18 months, we don't want you to get pregnant.
I'll take the next one. Perhaps I'll roll that into the following question, and that is, does the insurance company cover surgery if you don't have any obesity-related conditions? Again, great question. So insurance companies are very tricky. Both of our offices are well-versed in communicating with the insurance companies. Quite frankly, they change their guidelines all the time. So it's important that you communicate with your insurance company directly. We always encourage our patients to call the insurance company and ask if your policy is covered. Ask all of these questions because it's a process for sure. If your BMI is over 40, you typically don't have to have an associated comorbidity. With Medicare and some other insurance companies, if your BMI is just over 35 or 40 for that matter, you have to have a comorbidity. So I can't say for sure, but yes, indeed, you don't have to have one of these diagnoses in order to proceed with surgery. This sort of goes in line with the time frame for when you can have surgery, because again, it all comes down to insurance coverage to an extent. There are typical requirements that most insurance companies have, and some of those guidelines or timeframes include nutrition visits. We all have, or both of our programs have rather, nutrition as part of our program. So you can sign up with our nutritionist to satisfy this requirement. That can be a 6-month time frame. So you need to meet with the nutritionist once a month for 6 months in a row in order to be submitted to the insurance company. So just to outline that, if you were able to have your first visit with us, say within the next month or so, that means your first nutrition visit could be November. So November, December, January, February, March, April. We can't submit you to the insurance company until after that. They technically have 30 days to clear you. That gets you to May, and then we get you on the OR schedule. And that could be so sort of late spring, early summer. So that sounds like it's really far away, but I promise patients arrive on the day of surgery and they think that it flies by. There's a lot to learn. There's a lot to sort of digest in terms of the nutrition education process. So I think it's really important that you go through that. And hopefully that answered a little bit of the questions.
I'll take the next one. It's which one would be better, sleeve gastrectomy or gastric bypass, for a person with ulcerative colitis? So that, again, is a team approach. Both operations have been shown to help patients even if they have ulcerative colitis. Probably in most instances, we will recommend a sleeve gastrectomy, but not all. If you have really bad GERD, you're going to be better off with a gastric bypass. And you can be successful. If you're on steroids for ulcerative colitis, we would probably leave you on a antacid medication if you got a gastric bypass, whereas we may not do that if you had a sleeve gastrectomy. But again, if you have really bad GERD, you're probably better off with a gastric bypass.
I'll jump in on the next one. Would you recommend surgery or weight loss surgery if has stage 4 kidney disease and type 2 diabetes? So a lot of these questions I think that we'll be seeing revolve around your personal medical issues, which is great. So we'll talk some more specifically about how that pertains to you. We do these operations on patients that are in theory on dialysis or about to go on dialysis. Sometimes in order to be listed for a transplant of some sort, you need to lose weight, and this can be a reasonable bridge to that. We have to obviously be careful, but it's a conversation that we can certainly have, and we do operate on patients with these diseases.
And we definitely see kidneys improve after gastric bypass or sleeve gastrectomy with weight loss. It is not uncommon for the creatinine to get better. That doesn't mean it's going to completely reverse your kidney disease, but it certainly may slow the progression. So I think you talked about some of the pre-op steps, Dr. Lamond. I think, again, the insurance company may or may not require that 3 to 6 month weight loss attempt. Unfortunately, many of our patients have done a lot of weight loss attempts, but your insurance company may require that supervised weight loss attempt. So it's good for you to actually look over your policy and ask your insurance company, but we will help you with that and make sure you understand the insurance company lingo, because it can be tricky at times. Everyone needs to get a psychological evaluation, and everyone needs to see the dietitian to go over the post-op diet. I know people don't want to see psych. Most people feel they don't need it, and I understand that, but you should use it as a valuable time to talk about what are your triggers to eat and all, because obviously there are more reasons why we eat than just we feel hungry. So I think try and make it a valuable experience, because that's what they're there for. They're there to help you. They're not there just, say you don't have surgery. You shouldn't have surgery. So you should use that time. All these are ongoing and at the same time, and certainly if your appointment is not for a few weeks, you can start making that appointment to do a supervised diet. You can do it with our dietitians, you can do it with your primary care doctor, but you can get going on a supervised diet so that it's less time.
I'll tag on to that a bit just to reiterate what Dr. Schweitzer was saying. The psychological visit, that's a requirement by the insurance company. It is a very important evaluation, most certainly. If you already see a therapist or a psychologist or a psychiatrist, they can typically provide that. We do have a team of folks that can be that person for you if needed. I'll jump on to the next question, which is, why would there be a possible need for gallstone meds? So anytime a patient has a period of rapid weight loss, whether you go on the Biggest Loser show, you go on a crash diet, it puts you at risk for getting gallstones. So when you have weight loss surgery, you tend to lose a lot of weight. So that puts you at risk for getting gallstones. And when you have gallstones, that increases your risk for needing gallbladder surgery. So we put you on a medication that decreases the risk of forming the gallstones to decrease your risk of needing gallbladder surgery. I will say that years and years ago, we used to take everyone's gallbladder out when we did weight loss surgery because, one, this medication wasn't proven to really do what it's now doing. But we now know that we don't like to take gallbladders out willy-nilly, and it increases anesthesia time, it increases risk of a possible complication from having your gallbladder removed. So we don't do it without an indication at this point.
So the next question, is there proof that surgery will help with back issues, mainly stenosis? So what I will say for that is there is some data showing it does help the back, chronic back pain, knee pain, hip pain. But even more importantly, what you'll find is most spine surgeons don't want to operate on you until you lose weight. And part of the reason is, even if you need an operation, is to decrease the weight on their apparatus that they put in. The fusion, the plates work better if you lose weight. So in that sense, losing weight helps your spine, and that has been shown from either surgery.
I'll grab the next one. Can you drink soda after surgery? This is a good question. We get this one a lot. There are a few things in our curriculum that discuss soda. So one of the, multiple reasons why we would discourage it. One, typically sodas are high in calorie, and we discourage high calorie non-nutritional liquids. So that would not be a good reason. Also, sodas, as you know, are carbonated, and we really discourage any carbonation following surgery for a few reasons. One, it has a lot of air and gas in it, and it takes up space in your stomach that could be used for good calories and the high protein calories that we want to be in there. It's also fairly acidic in the sense that it can really irritate your stomach lining, and people don't feel well after they take soda or any carbonation for that matter. That being said, will you spontaneously decombust if you have a sip of soda? after surgery? The short answer is no, but by all means, we discourage soda for multiple reasons.
And that's the anti-soda campaign. I'll take the next one. I've had a minimum of 8 hernia repairs in 10 years, and I've had C. diff, diverticulitis, MRSA. Would that put me at more risk? It may. So what I would say with special conditions like this, in someone who's had hernias or some complicated abdominal surgery, the best thing to do, we're going to ask you to turn in a health questionnaire form to us that we can look over, is to get the actual op note. In this case, you've had 10 surgeries or 8 surgeries, is to get at least the last op note and turn that in with your questionnaire, and that will help us determine, and we can help you make decisions based on that.
I'll take the next one. It says, is kidney disease a health condition that would rule you out for surgery, or does it depend on the individual circumstances? We discussed this a little bit. So there are many stages of kidney disease. We certainly do operate on patients that are in some realm of kidney failure. As Dr. Schweitzer mentioned, sometimes your kidney function can improve. It doesn't always completely reverse the process, but you certainly can be still a candidate.
The next question is, what are the statistics for patients who keep the weight off versus those who gain weight back? Is there a study that you could read? Well, I kind of outlined a couple studies. One was Dr. Adams' study in the New England Journal of Medicine in 2017, where the surgery group on average lost 77 pounds versus the non-surgery group lost 6 pounds or less. There was the randomized a study out of Switzerland that showed 70% estimated body mass index loss. Our study, so at 2 years was 67%, at 5 years was 64%. So most patients will lose the bulk of their weight, as I told you, and level out at about 1 year to 1 year to 18 months. And then most patients gain a little bit of weight back, a few pounds to 10 pounds back. But there are about 20% of patients who gain almost all their weight back. And obviously, working with the nutritionist is a really important thing to understand how to keep the weight off for the long run. And I'm just going to go into a little bit of the talk that the nutritionist is going to go over with you, a very small amount of education on this for the long run. And the way these surgeries work, there's a restrictive component to it, meaning your stomach's smaller. You can eat less. And there's a hormonal part. The hormone ghrelin is made in the part of the stomach that's either bypassed in a gastric bypass or removed in a sleeve gastrectomy. So it's not activated. So when you normally diet, your ghrelin levels go up because ghrelin makes you want to eat. And it makes you go back to your former weight and then some. But when you get gastric bypass or sleeve gastrectomy, your ghrelin levels don't go up. And it's even more detailed than that. What they found with the Biggest Loser, the NIH actually studied these patients, and their metabolisms went down and stayed down even when they lost weight. And so they couldn't, their calorie amounts had to be less, where that wasn't true with gastric bypass or sleeve gastrectomy patients. So there's a lot of different factors. So it's important that when you wake up in the morning through the entire day that you eat correctly, meaning you eat healthy calories. You'll be able to eat them in less quantity, but you'll also be able to feel full longer. And that's how the surgery works, by having the ability to eat less calories, healthy calories, longer. But if you eat on, unfortunately, there's a lot of bad carbohydrates out there. One of my mentors used to say, nothing beats the potato chip. Well, nothing beats the potato chip. It's high calorie food, gets absorbed really quick, and you're hungry right after eating it. But if you wake up and eat a healthy breakfast, then you're going to feel full longer on less calories. And so that's how you keep the weight off for the long run. So it is important to develop those healthy habits. And so obviously try and keep you out of that group of the 15 to 20% that gains their weight back. And that's why I gave you averages, because not everyone's going to lose 80% of their excess weight. And that's why we talked about average weight loss when we were talking about the studies.
I'll jump in on the next one, which is, I have already been on an observed diet for a year under a doctor's care. Do I still need to wait the 6 months? So this revolves again around the insurance process a little bit. Fantastic that you've been under a doctor's care for a year. Typically, what we'll have you do if you've already been done essentially these nutrition visits is when you come to meet with your surgeon, you bring those records with you. We'll look those over because the insurance company is very specific about what notes they will take. So if you've been seeing a doctor, your primary care doctor, for example, but you're seeing them for an ear infection one day, and oh, by the way, they weighed you, and then the next month they see you for weight loss, and then the next month they see you, but it's titled hypertension visit. Sometimes they don't count. So we just need to be really specific about what we include. If they're all great, then they can be submitted as your nutrition. However, we do need you to visit with our nutritionist to learn a little bit more about nutrition as it pertains to weight loss surgery. Because typically those nutrition visits that are done elsewhere aren't revolving around a high protein diet following weight loss surgery in terms of volumes and that sort of thing. So there still are things to learn. The process can be shortened because you don't have to do the full 6 months, but there's still a process. It doesn't mean you can have surgery next week. We still need to put the package together, make sure that your site visit, we have all the pieces to the puzzle before we can submit you. I would still say that the minimum the process can take, give or take, depending on which center you go to, I'd say a minimum of about 2 months before we can collect all that data. And that's not to sound discouraging. It's important that we have all these pieces to provide insurance coverage.
I'll take the next one. What kind of surgical scarring should I expect? Most of the incisions are less than an inch. One may be a little larger than an inch or close to it. And usually it's about 4 to 5 small incisions, around 5 on the outside. You can get some scar tissue on the inside, but usually it's minimum with laparoscopic.
Great, I'll jump in on the next one. Would an appointment need to be made with the doctor for surgery first and then see a dietitian and psych? Again, great question. Lots of logistics here. I keep jumping in on those. So it depends. It depends which office you call. Sometimes, depending on the nutritionist openings, we're able to give you an appointment with the surgeon and the nutritionist, not necessarily on the same day, but at least at the same time. Our nutritionists are typically doing telemedicine visits at this point. We do have some group visits as well. So that's a work in progress, but all of the appointments can sort of be made in advance, pending the psychologist's availability, et cetera. But we can sort of outline that at the beginning of the process for you. But you don't have to see the surgeon first before the rest of the visits necessarily.
And our psych, some of them do televisits too, if you want to do that too. I'll take the next. I no longer have a belly button. Will this be a problem? It won't be a problem. That's fine. And then on the other one, how soon can I return to exercising after surgery? So we don't want you to do any heavy lifting for the first 4 weeks over 15 to 20 pounds. Walking's fine. You can do the bike or the Peloton. What I would say is try to be careful, especially the first 2 weeks. We don't want you dehydrating yourself. You're only going to be able to take in so many liquids a day. So we don't want you to sweat out too much in the first 2 weeks. But again, we want you walking, we want you moving. In about a month, people are usually back to their routine, somewhere between 2 to 4 weeks. So.
And that sort of leads into the next question, which is, I have a very physical job. How long will it take to return to work? after surgery. So first of all, the surgeries are equivalent in terms of return to work time. Don't say, oh, I'll have a sleeve so I can go back to work sooner. It doesn't work that way. It's really the same. If you have a very physical job, it really tags on to what Dr. Schweitzer was talking about in terms of heavy lifting. So if you have to go back to work and lift more than 15 pounds, then you're going to have to at least wait 4 weeks. It's really important to us that you do get back to work. So if there's any way that you can go back light duty or any sort of combination of things, it's really important to go back to your routines as soon as you can. In terms of time off of work, in general, for sort of a light duty situation or even working from home that we're all doing now to an extent, desk work or working from home, you know, my bias is that you need to give yourself time to recover and time to return to your activities. We give you a new full-time job following surgery, and that is in terms of being very persistent on taking your liquids, taking your vitamins at a certain time, and making sure that you have your protein shakes. And that takes a lot of energy and time, especially for the first week. It gets a lot easier, but you need to give yourself that space for the first few days following surgery in order to learn that. And so I typically say you need to take at least a week because people feel really tired after surgery. And again, getting these new routines, you're taking in less calories, your body has less energy, you're healing on the inside. So give yourself some time for that. And then by the second week, sometimes easily patients are going half time, sitting in front of the Zooms. They're off of pain medicine by this point. And it's really important to get back to those routines as soon as you can.
I'll take the next one. What types of safety measures are in place for patients who are having surgery during the pandemic? Good question. Very timely, of course. Well, obviously, if you don't know, everyone gets tested a few days before surgery, and then we want you to self-isolate so that you don't get COVID during that time. And we take safety measures inside the hospital now. It does actually take longer to turn over the rooms. We don't turn over the rooms as quickly because there's a lot more cleaning that goes on. Everyone's wearing masks in the hallways and when they go visit you in their rooms, along with hand washing with the antibacterial soap. So a lot has changed in the hospital, being even more thorough during this pandemic to keep you safe during this time.
All right, I'll take the next one. Is there an upper age limit for surgery candidates? It's always worth meeting with us. As I sort of mentioned on earlier, Medicare does cover this operation. So you certainly can be over 65. I believe the oldest patient that we've had in both of our programs combined is about 73. Not all patients are created equal. So as long as you can make it through the preoperative process and are interested, I think it's worth having a visit with us to discuss sort of the risks and benefits and long-term consequences. Absolutely.
So I'll take the next question. What if I don't lose as much weight as I want after the surgery? Can I have a second procedure? So that's actually a complex question and a very good question because, as you know, obesity is a chronic disease. It's a disease for life. And I will tell you, we take out a lot more bands than we put in or ever have put in. We don't put in bands anymore. But if patients lost weight from the band and we take it out, they gain all their weight back. Almost 90% of them are higher. And that's because, unfortunately, obesity is a condition for life. You can get another procedure. They never work as well as the first time. And I think that goes to a very important point. If you're in the middle of a divorce right now and it's the bad phase of the divorce, don't get your surgery. Wait till your stress level's lower. Because the first year to year and a half, it's really important to develop good habits for the long run. And so, again, that's why I take full advantage of meeting with a psychologist. You have to do it. The insurance company requires it. We require it. Take full advantage. Don't get surgery during your most stressful moment in life. Wait. Get some therapy, understand why you eat, and then get it done. But a long-winded answer is yes, you can get a second procedure if you need it. Any thoughts, Dr. Lamond?
Sure, I'll tag on to that for a second. like to say that the sleeve gastrectomy, we don't burn any bridges there. It's reasonable to go from a sleeve gastrectomy to a bypass, to a gastric bypass. We don't really go the other way around. You may find a few surgeons in the world that would take someone who's had a bypass and convert them to a sleeve. That is not a straightforward situation. We don't recommend it. We're all shaking our heads. So a sleeve can be converted to a bypass, just to reiterate. Is sort of that, can you have a second procedure? There are some other procedures that people, I think, had popped up question about in terms of endoscopic procedures, such as the gastric balloon. If you're interested in that, please just discuss it with us when you come to your clinic visit. Let's see.
So next one is, what disqualifies a patient from being able to have bariatric surgery? Well, that depends. So it's possible medical problems, but that's something we usually like to discuss in the office. It's possible psychological problems that are acutely going on. Again, we may ask that you wait, or our psychologist may ask that you should wait a year or two. Again, that depends. Those are some of the reasons. We would discuss them all with you. We have patients who have bleeding problems, blood clotting problems, heart attacks. So we certainly are used to seeing complex patients, but that's an individual discussion we would have with the patient for a reason to disqualify you or feel you're not a candidate at this time for surgery. There are very few, but there are some out there.
We'll jump on to the next one. Do you use a robot for weight loss surgery? We do sometimes use the robot. The robot is a method of doing laparoscopic surgery in a way. So it's done through similar small incisions. We operate by sitting on a console that is in the operating room. The robot does not make any movements without us making the movements. So don't think that it's just being done under remote control without any vision there. But we sometimes do use the robot, and we would certainly talk to you specifically about the pros and cons and the availability, frankly, of the robot. Because we both do laparoscopic and robotic, and there are pros and cons to both.
How long will I be in the hospital after surgery? Most people go home the next day. Usually you're in a recovery room about an hour and a half to 2 hours, and then you'll go to the floor. Within a couple hours, the nurse will get you up once you're not dizzy and all from anesthesia. The nurse will get you up and walk you around. We'll also give you some fluids that day. Not a lot, but we'll give you some. The next morning, we give you more, and the dietitian usually comes around to give you a little refresher talk and go over any questions you may have. And then most patients are gone late morning, early afternoon for both operations. So Dr. Lamond, you want to talk a little bit about why shouldn't I just get the balloon?
Gosh, there's a reason we didn't give the balloon seminar today. No, the balloon is about a 600 cc plastic, essentially, device filled with saline that is placed endoscopically into the stomach. It takes up space in the stomach so that you take in less calories and people lose weight. The situation with the balloon is that it's FDA approved to only be in place for about 6 months, then we're forced to take it out. It's placed under general anesthesia, removed under general anesthesia. As it turns out, when we look at these patients long term, patients tend to regain weight after the balloon is removed, as you can imagine. There is certainly a place for these procedures, I do believe. Sometimes if patients need a bridge of a 20 to 40 pound weight loss for an orthopedic type surgery, for example, to provide more mobility, to allow them to exercise, etc., I think it can be a reasonable option. But the data is really showing that after the balloons are removed, people regain weight, and then they pop into our office and then they want surgery.
Right. It's just like removing the lap band. Over 90% gain their weight back. So thank you all for attending our webinar. It was a pleasure. Thank you for the questions. Hopefully we can have even more discussion in the office. We look forward to seeing you. Thank you.
Appreciate it. Thanks, everyone.